Good afternoon, everyone. Welcome to the ICU Pharmacotherapy series. Today, we will focus on pharmacology management of asthma and COPD acute exacerbations in critically ill patients. My name is Ya-Han Lee, clinical pharmacist from Wan Fang Hospital. By the end of this session, you should be able to understand current pharmacology strategies for managing asthma and COPD exacerbations in ICU settings. Second, differentiate their pathophysiology and treatment priorities. Third, recognize how ICU persons optimize areas of therapy in both ventilated and non-ventilated patients and during care transitions. Okay, clinically, we all know that there are two international clinical practice guidelines that we often highly refer when dealing with asthma and COPD patients. Asthma exacerbations usually present with rapid onset and dry cough, while COPD, as the guideline from the GOLD guideline, the COPD exacerbations may progress more gradually and typically involve productive sputum. So recognize these patterns help guide our initial management. The asthma exacerbations, according to the GINA, the latest versions was in 2024, that it defined as acute or subacute worsening of symptoms, including dyspnea, wheezing, and cough. And its priorities is most of its emphasis on an increase in our patient's airway inflammation, causing bronchospasm and the mucus hypersecretion. However, the airflow obstructions that it oftentimes leading to tend to be reversible. In comparison, the COPD exacerbations, according to the GOLD guideline, it typically have pretty much similar symptoms. However, it typically, due to its repeatedly the increased airway inflammation, that the obstructions in the airway oftentimes is only partially reversible or sometimes irreversible. So that is the main difference. With a very even more details in the timeline with the difference that we can see here as asthma is mainly triggered. They have both different triggers, but asthma is mainly triggered by the eosinophilic inflammations that's often triggered whatever by the allergens, pollution, or viral infection. And its symptoms could be rapid, developed from hours to days, and with a course durations persistence from days to weeks. The average hospitalization course tend to be short from the average within 1 week. However, that the COPD, however, is triggered with inflammation process with neutrophilic cell that oftentimes driven by smoking, bacterial infections, or comorbid heart failure. So that's why understanding these differences explains why their responses to the corticosteroids may be different. And the course for the COPD exacerbations, here you can see it tends to have, compared to asthma, COPD AE tend to have longer presenting with the symptoms onset and a very slow process for the recovery from 1 to 2 weeks most of the times, and also tend to have a longer hospitalization course. As we introduced that the asthma exacerbations triggered with eosinophil inflammations that have a following process to the airway causing hyperresponsiveness. So you can develop it as an inflammation that can be that should become true. And most of the triggers that will be composed of both aspects, including environmental and host factors. Similarly, so the COPD exacerbations, that is the mostly triggered from the activates of the type 1 cytotoxic cell. So the neutrophil cell and the macrophage combinedly contribute to the following symptoms, including not just only hyperresponsiveness, but COPD exacerbations leading to the structural airway remodeling, which tends to be a long-term process, and dynamic hyperinflammation, and finally worsening the airflow limitation. So smoking oftentimes can trigger both, but is mainly the leading host factors in a COPD patient. So in ICU, with a patient that have a difficulty breathing, and we suspect with a long-term airway remodeling, not just from an episodic airway issue, that it is really important to ask the patient's history if this patient had any smoking history before, and how many years for that. Has the patient already been quit smoking for how many years? That will impact your differential diagnosis to see if a patient is actually had an undiagnosed COPD issue, and if that is related to any suspected exacerbations episode during this ICU admission. All right, so let's talk about some pathophysiology. So in front, the pathophysiology, both diseases share actually quite a final pathway, that is an airflow limitation. And overall, it first started with an inflammation that causes activity and causes airway swelling. So the initial phase that the inflammatory started in the upper airway and all the way down to the lower airway, which increased capillary permeability that leading airway swollen, and also some bronchospasms and these mucus plugging issues that has blocked the airway. So which, by let's say, it increased the resistance in the airway, right? So these eventually impaired the efficiency in terms of the expiratory airflow. So these limitations of the expiratory flow that due to airflow obstruction that steadily impair the VQ, which is the ventilations and the perfusion ratios mismatch. So this mismatch leading to finally further exacerbation, like because it takes it is going to take a longer or a prolonged expiration time for a finished or the air oxygenations exchanged from the lung to the vessel. So the alveoli fail by this prolonged expiration time. The alveoli fail to empty air trapping, to empty it efficiently, that cause the air trapping. So imagine the alveolar is just like a balloon in the lung, right? Whenever there is an ventilated and or the inspiration, expiration, it just increased and trying to inflame. So due to the insufficient during this prolonged expiration process because of the inflammatory issues caused, the alveolar is going to end up in hyperinflation all the time. So that is a second injury. But the final is the final pathophysiology that it caused is eventually our respiratory muscle is going to get in fatigue from these hyperinflammations all the time in the alveolar, and the poor efficiency in the oxygen's exchange is going to causing a hypercapnia, which is the CO2 is going to accumulate, and that tend to cause these like respiratory acidosis, unfortunately, and that's going to lead to progressive hypoxemia to the patient, and even worse is a respiratory failure. So a patient, if an exacerbation is really severe, that can cause the patient having presented with hypercapnia, respiratory acidosis, respiratory failure, and eventually maybe need an ventilator support, whether it's invasive or not. All right. So let's look at the treatment goal and how, before we treat a patient with an exacerbation, whether that is caused, that is the asthma exacerbation or the COPD exacerbation, how should we do the assessment, do the severity assessment? All right. So according to 2024 GINA and 2021 GOLD guidelines, let's start with the severe asthma. Okay. So once the CO2 retention develops with acidosis, this situation is critical. And the guidelines defines as severe asthma AE as any of the following criteria has been met, including the FEV1, the first seconds exacerbation threshold has less than predicted values on less than 50%, or an more severe episode that is below 40%, and a life-threatening scale is below 25%, and so on. Or if just the room air saturation for the oxygenation is below 90%, with either tachycardia with a BP more than 120, or respiratory rate more than 30, so that's the dyspnea episode. And as for severe COPD AE, that is defined is with a much more stringent criteria to meet. At least 3 of 5 criteria plus acute hypercapnia needs to be met. So these are both required for severe classifications. And we can see the criteria is actually, the element is actually quite similar to the component for the asthma ones, but with adding one more is, besides just the TPR, it also requires, it could be one of the meeting list if the patient's CRP is more than 10 milligram per liter, that is indicating a higher inflammation episode in the airway. All right. So now we know how is this acute exacerbation transforming, and how to understanding if the patient has already meet to an criteria of a severe level. How can we treat them? By knowing this pathophysiology. So we need to treat the cause. We need to not only symptom control, but also trying to put the fire down. So which is to put down the inflammatory issue in the airway. All right. So the treatment goals are pretty simple but demanding, that including 3 components to meet. First is from the origin to suppress inflammation and to ensure protect airway first. So ensure the adequate ventilation if needed, and maintain oxygenation. So that including with whether as a mechanical ventilator support or a bronchodilation from the pharmacology are essentials. All right, great. Okay, so understanding the fundamental elements. So pretty much you can think it, COPD exacerbation and asthma exacerbation is actually not that big deal to be panicked from, sorry. But we should emphasize and educate our patient and patient family really well. That is, do not underestimate from this dyspnea episode that can lead you to an ICU emergent admissions need. So here I'm going to emphasize two important components during an admission episode in ICU for these patients. First is the pharmacotherapy management. Second is how not only just deliver the medication, how can we deliver these inhalations, aerosol drug in a more efficient way in ICU with this ventilator. All right. So let's start with the pharmacotherapy management. So let's look at the components for pharmacotherapy management during these exacerbations. Whether it's asthma or is COPD exacerbation, there are four main categories of medications that are highly used. First is the inhaled bronchodilator, that it can be divided as whether it's beta agonist or is muscarinic antagonist, and both have a selections in using where it is short-acting for the acute phase or switch or add on with a long-term agent, with a long-acting agent. So the key considerations here I would like to highlight to you, including during the initiation phase of an exacerbations, it's important to carefully select which pharmacology category medication to use, whether it is beta agonist or should we select as a muscarinic, according to different disease type and the severity. And as for the inhaler formulations, it is very important to choose the right devices matching to patient's characteristics to find the most efficient way to deliver the inhaled aerosol. And as well, if the patient is intubated and supported with mechanical ventilator, and then the delivery process is important as well when choosing the device. And in terms of this, a more steady phase, which is recovered from an exacerbation, and then we need to step down a short-acting and convert or continue the maintenance set up as the long-acting medication, and even thinking of should we upgrade the component for these long-acting agents. Should we add into two components or triple components that should be discussed according to guideline suggestion. So besides the bronchodilator, the second medication category we often selected is corticosteroids, and this is an important issue field in discussing whether should we just using an inhaled route or in short as ICS, inhaled corticosteroid, or should we administer an IV or an oral form of corticosteroids accordingly. And of course, there are several considerations during an exacerbation initiation phase, which is if a patient need and administers systematically, then what is the best agent of steroids should we choose based on glucocorticoid efficacy or based on mineralocorticoid efficacy, according to its different mechanisms. And what is the dose and the best duration, because you should be aware that steroids have a side effect, including increased infection risk or increased GI ulcer or poor control in hyperglycemia. So the duration is important. We should step down from the oral form or IV form systematically as soon as we can. And then again, like who are the potential population that may need a systemic steroid. And the final two categories are including antibiotics and other miscellaneous medication. All right, so let's look at the specific guideline recommendations for the acute exacerbation. Let's start with the COPD according to 2025 GOLD guideline. Firstly, for inhaled bronchodilators, the GOLD guideline provides an evidence C level suggesting the short-acting beta agonist, whether with or without a short-acting muscarinic, are recommended as the initial bronchodilators to treat an acute exacerbation episode. However, when the patient has recovered from an exacerbation, to prevent a relapse, we should move on and continue as maintenance therapy with choosing long-acting bronchodilators, and that should be converted or switched as soon as possible without any further delay. Second category is corticosteroids. There is an evidence A level suggesting the proper use selecting of systematically corticosteroids can really improve lung function, especially for the FEV1, and also improve patients' oxygenations and shorten their recovery, and even shorten the ICU or the hospital stay. However, it should be noted due to steroids adverse effects, including an increased infection risk or poor control for patient glycemia, the duration of corticosteroids systematically should not normally be more than 5 days. And as for long term, if the patient suffers from frequent acute exacerbations episodes repeatedly, and also with an elevated blood eosinophil levels being checked, then it should be legitimate considering adding inhaled corticosteroids to the double bronchodilator regimens of LABA and LAMA. So that will become a triple regimens inhaled for these patients. As for the antibiotic, there is an evidence B suggesting if antibiotics is indicated, which means if the patient is highly suspected or confirmed with a pneumonia episodes, which commonly resulting from community acquired or hospital facility acquired. So antibiotics during these indications its use can shorten patients' exacerbations recovery time and also reduce the further relapse episode risk or reduce the risk of treatment failure and the hospital stay. An antibiotic duration should normally just within like 5 days, or maybe a little extensions depending on what kind, if a patient have a resistance of the infections pathogens. As for the other medications, you should be informed that the xanthines are not recommended due to their increased side effect profiles. So we should keep in mind for that. Okay, let's look at what does GINA's guidelines say about an asthma acute exacerbations. Firstly, for the inhaled bronchodilators, for the short-acting beta agonist, its roles should be started and highlighted as the same as a COPD AE. So the SABA with repeated doses usually be by the PMDI form, the pressurized material dose inhaler with spacer and control for the oxygens. We can start it from that. As for the SAMA, it can be used as needed role as reliever. In the asthma patients, a SAMA agent is less effective than a SABA, and also with a slower actions onset time. And the short-term use in acute care for severe exacerbations can be considered, such as like ipratropium plus a SABA agent reduce risk of hospital admissions compared to simply using SABA alone. So the combination can be considered for the short-actings. As for the corticosteroids in the asthma management during exacerbation phase, a GINA guideline suggests us can consider using as an oral form with agents such as prednisolone 40 to 50 milligrams or equivalent dose every morning for a continuous 5 to 7 days, about a week. But if a patient has not able to successfully recover from exacerbation until more than 2 weeks, and with that continuous use of steroids, then we should reduce the steroid dose, not just approve discontinue, but we should reduce dose gradually with what is we call a tapering before we just stop it. Alright, because we should avoid from any possibility of a steroid withdrawal in the patient. As for the antibiotic during asthma exacerbations, if you remember, a possible infection predisposing to asthma exacerbation, in those circumstances is often a viral infection instead of bacterial infection. So therefore, antibiotics do not routinely considered to prescribe in this asthma AE. And last is the other form. The GINA guideline recommend, if possible, try not use sedative, or we can infer or refer it as if patient has the pain issue or sedative issues during ventilated phase, then we should do as the pain control first principle during analgesia sedation. And also in acute care facilities, we can consider using intravenous magnesium sulfate with a boosting magnesium dose if the patient has an inadequate response to previous treatments. Okay, so let's look at a more precise recommendations for steroids. So the role of steroids here, it can inhibit why it is helpful in these two kinds of exacerbations. So if we remember, these airway inflammations is the first controlling issue or contributing to the respiratory failure in these patients. So in the short time or acute time, it's really vital that we can control this inflammatory process in the patient's airway if possible. But not just locally used, inhaled use, but sometimes we can try to use systematically. And so steroids that is helpful from many different mechanisms, including inhibit the gene transcriptions of inflammatory mediator and prevent the recruitment of eosinophils to airway, so you just block it on the way, and also to induce these in eosinophil cells apoptosis. And with both asthma and COPD's use, just remember that avoid very high doses if possible. And the steroids with a primary agent in selections that we would like to include a more effective strength in the glucocorticoid effects, like because it can generate preferred better anti-inflammations efficacies compared to those with higher potence in mineralocorticoids, if that makes sense to you. But for these agent selecting, we still need more studies and to suggesting whether at least A is better than B. But so in use, there is no real limitation, but just keep in mind with this principle in choosing the potency that we like to choosing those steroids presents with higher potency in glucocorticoid efficacy. And for the antibiotic, as we mentioned, just consider the general principles in treating CAP, community-acquired pneumonia criteria, and keeping the course within 1 week if possible. And it should also be noted for the interesting effect that sometimes for COPD patients especially, can consider to, if that is long-term, repeatedly heavy exacerbations event, then we need to consider whether to have the empiric coverage of anti-pseudomonas, if that means those risk factors, including that if a patient had a previously pseudomonas chronic colonization, or if it has a very poor respiratory functions, including the FEV1 is less than 50%, or have a structural disease or condition like bronchiectasis, or if the patient has already chronic steroid use systematically. Okay. And then for the other medications that we introduced the magnesium to you, magnesium is helpful in covering the asthma, COPD, or both exacerbation phase, because it has a very special bronchodilation effect by inhibit the calcium channels within bronchial smooth muscle. And by blocking a parasympathetic tone in the tracheobronchial tree is also helpful to recover an exacerbation phase. And finally, magnesium is also can trigger anti-inflammatory effect in our mast cell degranulation. And for the dose of boosting magnesium, that we would like, we often just give a single dose, 2 grams IV drip for 20 minutes, for examples. And for the evidence I will show you later with a very new meta-analysis. And others medications for the biologies we know is have the target receptors and target to a specific inflammations, like inhibiting just the IgE or interleukin-5, and for but its use right now is mainly for very severe phase refractory stage of asthma exacerbation, that including whether from the omalizumab, mepolizumab, or the benralizumab. But none of these biologics had developed for COPD AE. So it's primarily focused in asthma field, and is oftentimes as you can imagine, much more costly, and also have less availability to the access. Last is for the bronchodilations to inhibit like the PDE3. These have no roles, as evidence suggests, in both asthma and COPD AE. Okay, before we jump to more phase, I would like to introduce some more details, including the inhaler formulations that can better answer very important considerations that we should match the agents used to patients to meet patients' characteristics. So first common formulations, inhaler formulations, is the PMDI, in short, which is the pressurized meters dose inhalers. That is, whether you push as the meter dose, it can be compressed, and the medication is going to come out in an aerosol form. And actually, it suits for all the patient in different ages, from the children to the elders, and oftentimes it can often comes with a spasser, like we can link it to the PMDI, so it can better perfectly feed and reduce any demands from poor coordination. So the actuations and inhalation has to be composed together in this PMDI dosing. So therefore, for those patients unable to coordinate the hand-eye movement, because we will have to teach a patient whether you start in actuations and you have to hold your breath and for several seconds and then exhale. And sometimes that is a little hard to cooperate well, but with a spasser use, that adjusts much better in these agents. So that is the PMDI. And second category is the dry powder inhaler, in short as DPI. So as you can see, the DPI is with a very strong inhale that the powders inside the device can be comes out and exhale within to the patient's airway. But that really requires a very stable inspiratory flow rate. So if a patient, especially for the elder or children, is have very weak muscle strength or cannot cooperate or have a very powerful inspiratory rate, then sometimes the DPI is lessly choose, and because it provides just insufficient inspiratory force if the dose is not fully come out from the device. And then the third type is called soft mist inhalers, SMI. That is, it comes the medication comes out from the device. It's not a powder, but a mist itself. It's more like an aerosol. So it activates with a very smooth path, so the patients do not require to have a very strong breath. It just need to provide a steady lower flow rate, and so that is potentially suitable for most of the elderly patient because it is easy to conduct and successful agitation. But it requires a certain degree of coordination. So education is always important. And last group is the nebulizer, which you can see here, just a very small cup of the solutions of these inhaler medication form in solutions. And by generating the aerosols from the nebulizer, that we both have whether it's called a JN or a BMN, just a regular jet nebula, or with a vibrating peak that can keep generate the mesh itself. So come also with a smaller or a thinner particle. So these nebulizers, again, it has the most easiest conducting way, so that is suitable for all the ages patient, and is especially often used for these short-acting agents in these acute or critical illness status, and also is often seen to conduct an inhalations, selecting as a route administration route for these ventilated patients if needed. But however, the cost aspect for this nebulizer is it has a higher drug wastage compared to previous other categories, and is oftentimes not that suitable for the long-term use because it's a little complicated and takes time as well. So those are the devices that we can consider, and if the patients had been recovered from the phase. Here we have a long-term inhalers lasers as suggested, that do not forget. So after the patient has resolved from exacerbation phase, we do not just discharge the patient or discharge them to the ordinary ward with keeping the previous short-acting agents. We need to having switched to a long-term inhaler. So for the COPD management after a repeated exacerbations episode, the patient should at least on one long-term inhaler, whether it's LABA or LAMA. But if the patient after exacerbations, we can then adding an increase to as a dual agent with LABA combines LAMA. And especially if the patient has very high level, which is more than 300 in the blood, in patient's blood, then we can add in as an inhaled corticosteroids. So for those move on. And if long-termly, if this is not helpful and patients still have poor respiratory functions, and including have a poor FEV1 and also a chronic bronchitis event, then we can then consider whether there is a role for like roflumilast or adding azithromycin as previous smokers to helping with the immune modulatory. And then to consider the double role for the dupilumab in those with chronic bronchitis with a suspected high eosinophil form as the hypersensitivity like asthma type. As for the asthma later, after recovering from an acute exacerbation phase, that we need to go from step 1 to step 5 if needed, which included to prescribe a regular maintenance treatment that includes the inhaled corticosteroids is really mandatory in the asthma patients, whatever the phase is. So adult is preferred to using the ICS plus formoterol as the MART, and also try to more is preferred with the ICS formoterol more than just regular or medium high dose ICS plus the other LABA. And we need to emphasize and educate the patient to reduce relievers use to only as needed condition, because patients tend to think this is really convenient for them. If they have any discomfort, just this PRN reliever can help the symptom relief. However, if they just manage these respiratory symptoms by doing so, there is a really high risk that their asthma is not adequately controlled. They need a long-term agents, including the inhaled corticosteroids. Otherwise, just merely the PRN reliever is actually can long-termly deteriorate their asthma. It's not helpful for improving or long-term quality. And also we have to check the patient's inhaler technique and adherence as well. So these are, I tried to list you the common inhalers by the pharmacokinetic with the half-life group, from short-actings to long-actings. So these are the short-actings that we can often present with the SABA and the SAMA and or the combinations. And so their role in asthma and COPD are mainly for the acute phase, and we can combine mostly starting with the SABA first, and then combined with SAMA as adjuvant. And for the long-term agent use here, that we tend to have the LABA as a salmeterol or formoterol, and the long-acting muscarinic agent as whether tiotropiums or umeclidinum. And these are really importance in the asthma and COPD's long-term control, with a highly role as LABA goes with ICS, combined in the asthma maintenance management. However, in the COPD case, it is either oftentimes starting with LABA or LAMA, and then can combine with as a dual bronchodilator agents if needed. And as for the ICS, the inhaled corticosteroids that we have often seen, whether the fluticasone or budesonide, that both helpful in suppress the airway inflammations and edema. So for the ICS in asthma is the core for the management, right? Then we again have many in order to emphasize and helping with a better patient adherence or compliance to medication use. Then we have many different products with fixed combinations, or so-called maintenance controllers. Like you oftentimes see a serotype or a Symbicort that with the LABA and combines with the ICS. And you will see whether it goes to a LABA or LABA plus LAMA agent, that we have the products such as Anoro or Spiodo. Of course, they have a different formulation, but specifically, but it's in the same category of these two combined. So in the LABA and LAMA combination or dual bronchodilation, it is preferred for the gold severity level in COPD from the level B to D as a preferred use, better than just each single one. And as for the last one, as a triple therapy, here is not only just trilogy. I just list here as an example. We have at least 3 different kinds of the triple therapies in our hospital right now as a formulation. So a triple therapy including just everything together, like from the inhaled corticosteroids, the LABA, and the LAMA, and it can finally reach the full control with anti-inflammatory effect and plus a maximal ability for the bronchodilation. So for these 2 letters, as you can imagine, it is a triple therapy is highlighted as a very severe asthma or a very severe or persistent COPD phase as the advanced maintenance. All right, and here I would like to showing you some other information regarding magnesium to see whether in a real world if there is sufficient evidence to support a boosting dose from magnesium. So here we have meta-analysis come out with 14 studies, and it randomized people more than 2,000 with acute asthma. And for the primary outcome, that is to reduce hospital admissions, here you can see with these the pool meta-analysis suggesting that boosting magnesium dose compared to not giving them magnesium had a significantly less odds ratio. So it has less chance by giving magnesium, it can generate a less chance from patients admitted to hospital due to asthma acute exacerbation. So therefore, the intravenous magnesiums can reduce hospital admissions and improve from the other outcomes reported that I didn't list here. That can improve lung function in adults with acute asthma and who have not responded sufficiently to the other previous treatments, including oxygens and or the nebulizers or the inhalers. However, there is still very limited evidence for other measures of benefit and safety, just for your reference. All right, and the last part, now we know the pharmacotherapy. pieces that is important. But then let's learn about some other technique to how to properly enhance the efficiency to deliver the aerosol medications to our ICU patients. So here we will introduce several factors that can help more effectively conduct an aerosol drug delivery in the ICU. We divide the patients into two groups, which if patient is not ventilated or ventilated. So for the patients without mechanically ventilated, there are three main factors that can influence an efficiency of delivery in aerosol drug. That is the patient's host factor, the medications factors, and then the device choose for the aerosol. However, these three categories and factors and can all the same contributed to those patients that is mechanically ventilated. But there are two additional factors for these mechanically ventilated cases, that including the influence from a ventilator's parameter setting and also the circuits related. So we will start from these shared three factors first. First, let's look at the patient's factors contributing to efficiency in aerosol drug delivery, which is mainly focused about airway resistance functions. If a patient's airway is clear and patterned, and by that saying have a minimal secretion, and mechanisms of these airway obstructions itself can help the smooth delivery of the aerosol drug. And for the mechanical ventilated cases, like another patient's factor is if a patient is really synchronizing well to the ventilator. So if sometimes if the respiratory therapist reported to a team that these patients had poor synchronizing to the ventilator, then we need to address that issues in order to let this aerosol drug delivery have a better efficacy. And by how should we deal with these desynchronize? We can look at the PAD issue, right? The pain, agitation, delirium scenario. If any of these situations happen to our patients, like causing a desynchronizing. And let's look at the second, the drug factors, which have the several considerations with dose, choose, the formulation, and also the aerosol particle size, which is better suited for target for generating a 2 to 5 micrometer size. And what is our targeted size for delivery is also important as well, and also is duration of use, whether it's short acting or long acting, etc. So I would like to phrase a little bit more about the particle size. Here, that you can imagine a particle, when it comes into the respiratory systems, it would come out with several phenomenon. First is the impaction that hits into the bronchodilatic duct, and then when it comes to the lower end, it had the sedimentation that's down and going to accumulate in a certain place. That is time you would like to have a better target to the desired location. So we know that respiratory tract, when it comes from upper respiratory tract to the lower respiratory tract, is when it comes to the or even to a even lower side as the alveolar or other parenchyma side, the recommended generated particle size from this aerosol needs to be better target. So we would like to target 2 to 5 microgram meter. That is a better particle size generated, but we do not want the particle size to be too large or too small. If that is too small, for example, as below 0.5 millimeters, then micrometers, then it can be easily, these aerosol can be exhale out easily after a breath. So that is not a good example for that. So let's look at the device factors in terms of the inhaler formulations. So as you all know now, we have from the PMDI, DPI, and SMI, and SVN. So of all the four categories, the DPI, the dry powder inhaler, is unable to attach to ventilators use during the ventilated process, so it's lastly choose. Other than this one, for the other three, the PMDI is able to generate a final decrease in the size targeted from 3 to 5 micrometers. And as for the soft mist inhaler, such as Spiriva or Spiriva, because it has a Respimat formulations that have really relatively good small particle size reached within a proper release time and have a effective lung deposition rate of 45%. And as for the other 40% is depositions in the oral form, so it becomes ineffective. And as for the small VN, those nebulizers such as the short-acting Saba and Sama, that because it has a really, although it generates really small, it can be generated as a small particle size as a 0.1 meter micrometers, but however, it has a very heterogeneity in the dispersed aerosol size. It could be large to 500 micrometers, so it's not that steady. And also, some SBNs stop producing aerosol when it tidal 30 degrees from vertical. So it's really important to have a very good technique in drug delivery. Otherwise, if it's not keeping just the horizontal position, then it can be less effective to generate the nebulized form in those ways. So as take-home point here for the aerosol device for a PMDI is highly choose. That can be linked to a ventilator as well. So it oftentimes need another spacer or adapter to help better connect it and linked so the patient can breathe easily with these aerosol form medications. And however, there is issue for the position of spacer as an increase in the circuit. And the timing of NDI agitations and the type of form is also should be into consideration. And as for the nebulizer, such as these small SBN, this form that has be also not just the small size is good enough, but also the field volume, the gas flow, and the duration, how long you would like the patient to be inhaled from these solutions, remember, and also the positions of the circuit is all matters. And cycling in the inspiration route or is a continuous form, it can all generate different efficiency. And here is some more explanations of how to add spacers or holding chamber to PMDI. So like it had multiple forms from the hand holding spacers, like for children can conduct well and help themselves to breathe easily, or they can also be used for conducting with PMDI and also be linked with a jaw spacers to the tracheostomy tube or the intubated tube. So there is another specific form that emphasizes is material of this chamber is non-electrostatic, so that can also being helpful in conducting a better efficiency of delivered aerosol. All right, so these holding chambers allow exhaled aerosols to remain in the chamber and remain available to be inhaled with the next breathing time. So patient can be inhaled the medications needed in a more smooth pattern. And these devices provide less overall frontal deposition by retaining larger droplets and increasing respirable drug dosage. So this chamber can minimize the cold film effect and any bad test associated with the drug. That is an additional point to that. As for the useful in the administration of steroids, because this deposition in the drug in the mouth is largely eliminated. Here is the bar chart I like to show you, seeing how is this pMDI finally distributed after an acute agitation, whether it is the most of the proportion of aerosol depositions in whether in lung or in the upper airway or still in a device, or it has been expelled out. And they try to this bar chart try to tell us with these informations within different types of the aerosol device. Here we can see the ultimate goal is to find the largest proportion that have the most aerosol deposits in the lung, which goes to the best one is the pMDI, that is with a chamber, especially is the non-electrostatic type. And the second component of the device is pMDI with spacer. But if we just merely give patient using by a pMDI without spacer, then we can see the deposition rate in the lung has been lowered, decreased a little bit compared to the previous one. All right, so that is the difference between the two. So the take-home point from this one is transition nebulizers to inhalers as soon as patient is stabilized to promote teaching and earlier hospital discharged, because these NDI or DPI with spacers and nebulizer can provide similar effect. So when patient has been improving and recover from an exacerbation episode, we need to try to switch to the formulation from the SAMA to the long-term acting agents. So we need to decrease the nebulizer form. So nebulizer here is preferred to patients who are critically ill and unable to cooperate with inhaler. But when there is a chance that patients become more stabilized, then we need to switch to whether pMDI with spacer or DPI. The patient can conduct really well and have a good adherence by themselves. Otherwise, with a pMDI with a chamber that is non-electrostatic is the best choice of all. And to providing you some more details with the different nebulizers, that even just nebulizers, it also have some several different adapters that can have each advantage and the drawbacks to know. First is the jet nebulizer. So its pictures look like this. It's just very simple with a small cup or the device that can put the solutions in, and then for its pros is that it is very low cost and easily accessible to use, and it has very small dimension and it's single use. However, its drawbacks is it had really poor low drug delivery because you need to come out trying to nebulize the solution first. So it has less efficiency variable, and it takes longer time for a finished nebulization. Sometimes for the human power considerations, it also taking some more labor intensive work. And through a jet nebulizer, it has less than 50% of the dose delivered successfully to the lower respiratory rate only. And the second for nebulization adapter is this ultrasonic nebulizer that come out with a vibrating skill by using an ultrasonic way. And its advantage is it had a better, higher percentage in the dose delivered to the lower respiratory tract. However, as you can imagine, ultrasonic is really sensitive to the solution temperature effect, and that could sometimes, during this vibrating, the increased temperature can occasionally influence the medication stability, and it also had a higher cost and less availability to get it. And the last one is the vibrating mesh nebulizer, and again, it has the highest dose delivers near to 60% to the lower respiratory tract. And however, it generates the nebulizer by the mechanism with the vibrating metals in part in this nebulizer adapter. So that's the reason it can come out with the best efficient drug delivery. And provides with a relatively constant in solution temperature compared to the ultrasonic nebulizer one. However, the drawback is it again has a high cost, and it is really sensitive to those medication that is in a higher concentration and also more viscous solution like antibiotics. So in this form of the aerosol device that we can refer to according to there is a review article as I listed here. For the mechanical ventilated patients specifically, it is actually recommended that using those aerosol device with whatever the vibrating mesh nebulizer or simply just PMDI with a spacer are recommended for aerosol delivery with a strong recommendations. And for the nebulizers, when there is a bias flow, it is recommended to place the nebulizer specifically with in the inspiratory limb, away to note that to put away from the whitepiece and towards the ventilator. That will be better helpful in conducting. And for those choosing to link the device with a PMDI to the ventilator, it's recommended that with a spacer with a larger volume will be better, and place the same in the inspiratory limb before the whitepiece, and to deliver an actuated dose at the beginning of inspirative flow. That will be helpful as well. Okay, so let's look at the different mechanically ventilated. But firstly, we should note what is the goal for the oxygenation supply device that we can use not only for the there's not only mechanically ventilation, but also other devices is also helpful to deliver the oxygen supply, right? So the ultimate goal here is all we can use, whether it's just a simple oxygenation with a nasal cannula, or it's a non-invasive mask that the patient can wear, and also the invasive mechanical ventilation, or just a much more invasive one, which is the VV ECMO. Each one has its own parameters, the monitors, and the indication, and oxygenation goal for these asthma or COPD patients should target differently. For asthma patients, to target the saturation oxygens at between 93 to 95%. For COPD patients, target at 88% to 92%. That is from the guideline. And as for the NIV, the non-invasive one, should be the first mode of ventilation used in COPD patients with respiratory failure because it improves gas exchange, reduces burden of breathing, and need for intubations. If a patient had a rarely choose, and it's the indicator that we could do. And the other indication I often see here is for the respiratory acidosis, that these COPD patients oftentimes present with the hypercapnia symptoms. That is the one that we need to be helpful to use. As for the mechanically ventilated, it doesn't just only indicate it for patients with COPD or asthma exacerbation, right? Just all the area protection formed from patient with a legitimate need in ICU, whether it's from cardiac arrest or hemodynamic unstable, can be all indicated to intubated. So that's varied beyond in this topic. And these are the aerosol device that I just mentioned to you. That is how we connect those to the mechanical ventilator. So for the small the SVN that can just connect and recommend for the comes in the inspiratory limb. And if for the MDI4, then it is also conduct, whether it's just conduct to a non-invasive mask or to a tracheal tube or intubated tube, endotracheal tube, that we oftentimes to insert the MDI and with a connected spacer to enlarge its actuations distribution space. And as for the SMI, that there is also another connector looking like this one that can be specifically as a Y piece to insert the SMI through the tube and connecting to the main tract for the circuits of the ventilation. And then we need to know a few about the ventilator parameter. You must be wondering, there are so many different parameters of a ventilator setting, whether it's FiO2, height PEEP, the volumes, or whatever. But actually, whatever of these parameters in the ventilators, there is actually no proper recommendations from these the current literature review. The experts failed to recommend a specific type of the ventilator parameter settings to improve the aerosol delivery efficiency. And however, for the circuit-related issues, we should keep in mind that if a patient that is mechanically ventilated, whether it's by an endotracheal tube or a tracheostomy tube, that means the circuits being enlarged, the patient's airway has been larger and longer. So that would impact the delivery and the dose needed for an aerosol, right? So again, for the literature review from this article, not recommend for us any sole purpose of improving aerosol delivery efficiency to change this ventilator setting. And also specific mention for the humidifier of the circuit of the this mechanically ventilation. Turning off the humidifier is not recommended for just routine delivery of the aerosol. So here is a demonstrations for an increased circuits from invasive ventilations with a specific artificial airway and a lung. So from the directly from the aerosol delivered to the lung, that is have a longer airway, right? And the same idea for a non-invasive ventilation, whether it's a nebulizer or the PMDI, that is also had an increased rate circuits from the starting from the non-ventilated mask and also from this exhalation valve part. So the last sections I would like to share today with you is the dosing considerations for these SMI by an example of using the SMI and endotracheal tube. So here, this is a research conducted in Taiwan that the physicians, the researchers trying to compare using a mechanical ventilation compared to another machine that is can come out with a stimulated spontaneous breathing, and try to compare the same doses that whether it is conducted differently by a stimulated spontaneous breathing or the endotracheal tube with the same drug delivery of the SMI. Okay, so they figured the inhaled tiotropium actually with a simulated spontaneous breathing that was nearly reached a 3-fold greater than the administrations through the endotracheal tube that effectively to the breathing model to have an efficient drug delivery, a 3-fold difference. So that means conducted drug delivery through a mechanical ventilation will come if you give a same dose as well. Patient is not ventilated and will have their own spontaneous breathing. Then we know the same dose will generate only at a relatively low concentration or proportion as in terms of the efficiency of these areas of delivery if connected to the ventilation. And this is another example showing you by using the PMDI or small nebulizers that connecting to the endotracheal tube. And here you can see the response to dosing the albuterol administered by the PMDI that was delivered. A 4-puff here is equal to 0.4 milligrams. It was comparable to that achieved with 2.5 milligrams administered by the nebulizer. So here is the other chart showing you different formulations with different types of bronchodilator and with the recommended dose and the frequency. And here, that's the take-home point I'd like to point out is the higher dose of bronchodilators may be needed as you see that the higher nebulizer dose can come out with just merely the same rate of the maximum in terms of change. So the higher dose of bronchodilators may be needed in patients with severe airway obstructions. So how can we do with the clinical application? A key clinical point is routine use of standard outpatient MDI dose during these acute exacerbations and stay in the ICU and ventilated stage often leads to a very unfortunate suboptimal bronchodilation effect. And how should we deal with that? We increase the dose. We increase the dose to by consensus is we double dose. A 2-fold increase in the MDI dose. Those may be justified clinically in these circumstances. Whenever the patient is had an endotracheal tube or a tracheostomy tube, because the larger circuits need a larger dose to compensate and to deliver to compensate generate a better or a the same drug delivery efficiency as the outpatient stage. Okay, take-home points of today. Asthma exacerbations is characterized by bronchospasm and eosinophilic inflammation, while COPD AE is driven by mucus unplugging and neutrophilic inflammation mostly. And bronchodilators and corticosteroids are the cornerstone therapies, but drug delivery device selection must be tailored to patient condition and also the need of ventilation mode. And third, inhaler device choice can significantly affect pulmonary drug position and the affect therapeutic response lately. In critically ill patients, thus, those choosing with VNM or SMI or PMDI with a spacer is preferred. And MDI dose, if possible, should be increased. Empirically, we double the dose when used via endotrachea or tracheostomy tubes to deliver an agitation. Thank you for your participation.